Welcome to the award-winning Women in Healthcare Leadership podcast series brought to you by Medscape Education. Our mission is to educate, advocate, and inspire women in healthcare to lift as they rise. Each episode brings you voices of leaders who are breaking barriers and leading the way in advancing women's health. Join our global community of listeners as we hear from her. Ready to be part of the movement? Let's dive in.
Welcome to Hear From Her, where we elevate bold voices, reshaping the future of healthcare. I'm Sarah Thorpe, your host for today's episode, Voices of Change, Women Leading the Menopause Movement. Today, we are peeling back the layers of stigma, misinformation, and clinical gaps that have left too many women unsupported during one of life's most transformative phases. Together, we'll explore what it means to challenge outdated narratives, push for better education and access, and design care that finally meets women where they are. I'm excited to introduce today's guest. First, we have Dr. Alyssa Dweck, Chief Medical Officer at Bonafide Health, practicing gynecologist, and Menopause Society certified clinician. Welcome.
Thank you.
And Heather Maurer, Chief Executive Officer of the National Association of Nurse Practitioners in Women's Health. Welcome.
Thanks, Sarah. It's great to be here.
And Dr. Mary Jane Minkin, a Menopause Society certified clinician, practicing OBGYN and professor at the Yale School of Medicine. Welcome.
Thank you very much, Sarah. Appreciate it.
Well, let's get into it. So I think for us to understand where we need to go in the space of menopause, it's important for us to lay down the conversation and hear from you about where your story started. What led you to step up and become a leader in this space? So Dr. Dweck, with such a rich and diverse career, from delivering thousands of babies as a practicing OBGYN, advancing female sexual health, and now as the Chief Medical Officer at Bonafide, what initially drew you to focus on menopause care?
Yeah, thanks so much for asking. I can honestly say I did not enter medical school or residency with the intention of being a menopause provider by any means. But they always say your practice ages with you. So as practice went along, my patients stopped having babies and they started entering the perimenopause and menopause spaces. And naturally, I was growing up with them. So that's what really gave me interest. It really is an underserved space. We didn't get much training in medical school or residency in menopause or perimenopause. So it was sort of a learn on the job and learn as you go situation. And then lastly, I had a background in nutrition before I went to medical school at the master's level. So it was only natural for me to want to pursue that interest as it relates to my medical practice.
And Heather, I'd love to hear your story too. How did you first get involved in this space? And for our listeners who may not be as familiar, can you explain the role that women's health nurse practitioners and other advanced practice nurses play in supporting women's health through the stages of life?
Absolutely. So my journey, and I echo prior comments, when I was younger and thinking about having a family, for me, maternal health care was, front and center. And then I am proud to say that I am officially a crone and I am in full menopause. No more perimenopause for me. Coming into this role as the CEO for the National Association of Nurse Practitioners in Women's Health, what I realized was in my personal lived experience going to providers for care, as well as working with our NPs, is that, first of all, the science is now in a different place than it was 20 years ago when the WHI put a pretty much big halt to providing HRT for women. Providers are digging out of that gap and making up for it. And it's not just the women's healthcare providers, it's all healthcare providers that have a lack of knowledge. 6 years ago, I had a frozen shoulder for over a year. And 6 years ago, I was absolutely, in hindsight, in perimenopause. Not one person said, "Hey, you're in perimenopause. This might be an estrogen related thing." I went for PT, I did all these things, and honestly, nothing really worked until it just worked itself out and healed. So I'm very dedicated to providing continuing education through MPWH for advanced practice providers to help close the gap. Women's health nurse practitioners are one of the NP population foci who specifically focuses on women's health care across the lifespan. And many of our WHNPs are also certified from the Menopause Society and have received that extra training and have specialized practices focused on this area.
Thank you for highlighting how our personal experiences can really fuel that professional passion here. And so now I'd like to kind of build upon that, Dr. Minkin, and bring you into the conversation. You've had such an impressive career as well, spanning clinical practice, teaching, advocacy, really reshaping how we're thinking about menopause. And I know Dr. Dweck, you mentioned gaps with education. I know that's a passion area of yours as well, Dr. Meekin. So, was there a particular moment, a patient, or experience that prompted you to want to step into the space of menopause?
Well, I think there were a lot of moments that made me go into it. I was actually extremely lucky, and part of my devotion to education, I think, is because of the fabulous education I got. When I was a little kid in medical school, my teachers on my OBGYN rotation were three people, among others, named Spiroff, Glass, and Case. And they wrote, while I was still a medical student, the textbook, which is still enduring for teaching clinical gynecological endocrinology and infertility, and menopause being one of the topics they were devoted to. So I got this education when I was a very little kid, and I basically stuck with it. And over the course of time, obviously, as Alyssa points out, that we start delivering babies when we're young, and that's what we do with most of our career, but we age with our patients. But one of the things, of course, that happened along the way, and this again is partially my significant devotion to education, is when the Women's Health Initiative came out, menopause education stopped on a dime. That was it. We were done. It was just July 9th, 2002 when this all happened, 9 o'clock in the morning. Now, I remember it all very clearly. I think most of us who were practicing then do. And what happened is at that point, menopause education ceased. And the other problem that was going on is that residency programs were trying to shorten their hours to go from 120-hour a week residency hours that we did when we were little kids, in OBGYN, and they had to cut down to 80 hours. So what do? You cut menopause education because, hey, nobody's going to take the hormones. Why bother teaching people around it? We still had to teach kids how to deliver babies and do hysterectomies. So menopause education disappeared. And indeed, one of our good friends, Dr. Wen Shen at Hopkins, did a survey about 10 years after the WHI came out. And she surveyed all the residency programs in Canada and the US and found out that menopause education was being taught in 20% of them. And the sad thing is that our friend Peter Schnatz's group repeated the study about 2 years ago and found out it was a big high of now 30%. So we're still in basically a menopause desert in a sense. However, what's happened, and this was also significantly patient driven, is that about 2.5 years ago, an article appeared in the Sunday New York Times saying women have been misled about menopause. And that just triggered a huge revolution in women seeking menopause education. And they were like, "Hey, what happened to us? We got left out here." Yeah, you did. So I really, that's again a passion I think of everybody here as far as trying to teach our practitioners who haven't been given the opportunities that we had to learn about menopause to get them on board. And I think it's vitally important to get all docs, nurse practitioners, PAs, all of us involved in taking care of our patients who desperately need it.
Thank you for that. And what you're starting to speak to are some of those deeply rooted challenges in the space that we face today, the legacy of the WHI that's leading to this menopause desert. So we know that menopause impacts half the population. So why does it remain so underrecognized in mainstream healthcare? Is it stigma around aging and reproductive health? Is it the clinical training piece here? Or are these issues reinforcing each other? So I'd like to pass it back to you, Dr. Minkin, and then have others chime in on.
Well, again, there's the lack of discussion and education for many years. I mean, that's out there. That's number one. As far as menopause as an entity, unfortunately, menopause, we go through menopause as we're getting older. That's one of the problems. And in this society, we unfortunately don't value older women. The people we like are these young folks and older women. Now, fortunately, we do have significant role models. People who are fabulous are now recognized as great people. We're finally paying attention to that. So that's one of the major issues there. The other issue, of course, is, women as opposed to men. And oh, this is something that just women have or something like that. Young folks listening won't know the show, but there was a show on TV called All in the Family, which was extraordinarily popular. And the leading character was Archie Bunker and his wife Edith. And the menopause episode, which I think actually won an Emmy, was Archie saying to Edith was sort of getting a little loose ends and stuff like that. And she was like, "Doo-doo," and and Archie says, "Edith, what's going on?" And she's, "Archie, it's the change." And he says to her, "Edith, get over it." And that was it. And that was a very famous episode. And so the people have dismissed menopausal women for many years. So I think that a lot of it's stigma. A lot of it's, I now think we are paying more attention. Women are out there doing it. And they're realizing that women, and again, the other thing that issues that are coming up are women in the workplace because we have a large number of women in the workplace, and many people find that women going through menopause, and some of our leaders have documented the costs of menopausal symptomatology to workplaces. So people are now paying more attention to it. And the other issue that I think that we need to pay attention to are foreign countries. For example, England, they are paying far more attention to this, and issues about menopausal health in dealing with women in the workplace have been addressed years ago by our British colleagues, and we're catching up.
I would love to add on to that because, and I really echo all of those sentiments. I think the other thing is that for so long, there really was very little research being done specifically in women. In other words, women were sort of considered little men in terms of extrapolating results and applying them to women's health, which really just isn't the case. So I think we are seeing an improvement in more and more women in research. So that's something that should be highlighted. In addition, I think that with the WHI and for other reason, of course, there's been a little bit of mistrust in the medical system, lack of access, and, real medical deserts, which of course hits the menopause and perimenopausal populations. As well as other health needs. So, this is something that is definitely being addressed, and I think in a positive direction right now.
I'd also like to chime in. I agree with all the sentiments that have been stated, but I also want to talk about right now, present day, because right now, what we're seeing is a shift in the value of women's health, where we're cutting funds. We are no longer underwriting research, and I have great concerns about our future and this being prioritized when people aren't going to have even access to primary care, let alone specialized menopause care. So I do think we've made some progress. I do think when the WHI was reevaluated and a new look at how that data was presented 20 years ago and what it really said and the new research, yes, there's been progress, but there's been a huge stall that's been put in place in the United States.
Well, I'd love to take the opportunity to really highlight that many private companies are conducting their own research and development. And that was one of the reasons that I was so excited to take a leadership role at Bonafide. We research our products only on women, and it's done privately. And of course, we're not a pharmaceutical massive company, but I think a lot of the private companies hopefully will fill some of that void.
Yeah, I think that's a really great point. And Heather, I would love your take on how advanced practice providers and nurse practitioners in women's health can play a role in helping contribute to some of the access challenges that we might see in the coming years.
Right now, there are 13,300 and some change board certified women's health nurse practitioners in the United States. 27% of our members work in rural and small towns. And I think also with there's going to be some significant changes to funding nursing and medical doctor education. I think we're going to see a big shift in what happens to our workforces. And I'm concerned that we're going to lose the specialization of MDs. Most of our providers work in collaborative practices across, and 75% roughly work in OBGYN offices, whether that be in private practice or in hospital settings. And of course, we have folks that are working in federally qualified clinics across the country, which are also on the brink of closing. So, our role is significant in that we are able to do much of the same work. Obviously, we have different scopes, and I very much respect that, as do our providers. However, in terms of taking care of perimenopausal and menopausal women and walking them through the journey to get care, whether that be with HRT or non hormonal options and methods, which, thanks to the investment in these options, there are many more on the market in the past 5 years than there were prior, and there will continue to be new products coming to the market. But WHNPs can take a leadership role in supporting women and individuals through this time and transition, as well as bring information to the whole practice, to the whole hospital, to help educate others and encourage them and provide them with opportunities to gain more insight. I, as a patient and a non-provider, I'm that patient that Alyssa and Mary Jane are probably like, oh no, but I bring all these studies to my primary care person who's not a WHNP or an OBGYN and say, hey, here's all this great information about menopause and perimenopause and vaginal estrogen and all these different things to help close the gap in that office visit. Because again, like I said, I suffered for over a year with a frozen shoulder, and not one person said anything about estrogen and, oh, let's run your panel and see where you are. So I think it's really important to that we all play an active role, and that patients bring information as well. As we know, today's providers have 15 minutes max with their patients. It is near impossible to truly get a patient's history, especially a perimenopausal woman's history during that time. And so everyone has to play a role in helping maximize that time together.
And I'd like to add, I think organizations like Medscape can do a tremendous job of educating people, educating practitioners, educating, the docs, the nurse practitioners in women's health, because basically menopause is an extremely time consuming issue. And the more education we can get out to people and share it with our patients, the better it is. Because, and again, one of the other concepts that ties into, it drives me crazy when people think of being a specialist in menopause. Everybody should be a specialist in menopause. I mean, it's like, oh, I'm a specialist in, in delivering babies. No, I mean, delivering babies, more women, God willing, we live long enough, we're going to go through menopause. Not everybody's going to have a baby. So we really shouldn't have to have specialists in menopause. Everybody should know about this. But it's really great to have educated patients and sharing the education with practitioners and patients to get everybody on board and give them a basic education of what we're dealing with, because this gets tricky. And again, menopause is very time consuming. So the better educated both the practitioner and the patient is, we've got a much more of an alliance there and can get their care taken care of much better.
Yeah, I'd like to make a shout out to so many of the entrepreneurial minds out there that have really tried to overcome some of the obstacles. So, for example, many of the telehealth platforms that focus on menopause and perimenopause really can fill such a void and gap, especially as Heather mentions, with the time restrictions that many of the physicians and perhaps nurse practitioners face every day in their practices. So I always think that, necessity is the mother of invention. And that was one of those prime examples, really coming up with these menopause and perimenopausal platforms.
Yeah, I think that's a really interesting point. The need to personalize and provide options, innovate, because there is this disconnect between the number of women who are experiencing symptoms and those who are actually receiving support. So I want to dig in a little bit more about what you're hearing from patients. What kinds of feelings or concerns are they bringing about with their symptoms, and how are they navigating this stage of life?
Well, I can take a shot at that one. How much time do we have, right?
We have 15 minutes.
Yeah, I'll go very quickly. The iconic symptom of menopause, of course, being hot flashes and night sweats, which we love to refer to as vasomotor symptoms of menopause. And I think it's well known at this point, and should be by primary care physicians and practitioners as well, that 80% of women going through the menopausal transition are going to experience this, and a smaller percentage of those women are being treated. My goodness, we hear about the 34 symptoms of menopause and then the 107 symptoms of menopause, and the list goes on and on. So, really, there are symptoms that are quite individual. Everybody has a very different experience. To that point, there are lots of different options to manage these symptoms, but I just want to put a first plug in for lifestyle modification, diet, exercise, sleep, and stress reduction. These are just four, like, pillars, if you will, that must be addressed no matter whether somebody wants to be on hormones, drugs, herbal supplements, or the like.
We have to explain to our patients what the symptoms can be. And then, though, we occasionally get people who go to the other side as far as saying, every symptom I have is from menopause or perimenopause. Okay. And there, and it's very hard to differentiate, to say, is this a menopausal thing? Is this not a menopausal thing? It's hard to dissect out what's what. And there's probably a component of both lifestyle, and hormonal stuff going on contributing. So we have to work on trying to sort out what's going on to help the patient optimally.
Yeah, to your point, Mary Jane, it is so important to rule out medical issues first, because we don't want to miss things that may be managed in a way that it's not just a menopause symptom, but it really is a medical issue. So it really takes a team to untangle all of this.
That's a really good point. Where, just because you're 45 and you're coming in and you have this laundry list, like, the easiest thing to say is, "Oh yeah, it's menopause. Let's just give you X, Y, and Z." There might be underlying things, and I think that's where the complexity comes in treating folks. And again, I say this because it just really upsets me. 15 minutes, and you're trying to navigate this. It's just unfair. It's unfair to the patient. It's unfair to the clinician. We really need to figure out how to change this model. I just got a report that on average NPs are seeing 32 patients a day. 32 patients a day. How do you divide? What? How much time are they spending with them? So it's a huge concern.
You know, That just so resonates with me. Yeah, speaking of leadership and career paths and whatnot, I literally changed the nature of my practice from a big, huge multi-specialty group that had been, corporatized, if you will, to now a much smaller private practice where time is afforded. And, it's made all the difference I feel, in my care to my patients, is the time management.
Absolutely. The system isn't set up for success as it currently stands. And my focus, as the leader of our association and in collaboration with others, we do a lot of work with ACOG and A1 and ACNM and ANA and AMA, and the list goes on. But to really look at, okay, so we know all the problems. What is it that we're going to do? How do we want to recreate this? How do we want medicine and care to look like in the future? And let's focus on building that. And this time frame thing is definitely needs to be addressed.
So, if we were to build a standard of care model, early conversations, routine assessments, tailored support, what would that look like, and how might that improve long term outcomes for patients?
Part of the problem is that menopause is, well, it's not as easy to diagnose as it used to be because people have all these things going on besides hysterectomies. They have IUDs put in, they have ablations. You can't figure out when they're fully menopausal. Makes it a little trickier. But perimenopause is by definition even more amorphous. And it's very hard, it's very unpredictable, and it's very difficult to treat. And that's one of the things. And again, that gets into the what's perimenopause and what else is going on. So it's a really tricky situation. And again, as you know, both Alyssa and Heather have pointed out, that it's a very time consuming process. So we just have to, train our young practitioners coming through to say, okay, these are some of the guides, and you're never going to be right 100% of the time. And the other problem that's out there that ties into that is the continuity of care issue, which is huge. Because, if you have somebody who's changing their health plan every 20 minutes because someone's going to give you a $10 cheaper health plan, which unfortunately is what happens these days, is there's no continuity of care. And somebody, when you've delivered somebody's babies and now you're seeing them go through perimenopause, it's a lot easier to do and a lot more fulfilling and good for the patient than somebody that you met 10 minutes ago. And that makes it problematic.
So we touched on treatment a little bit, but I would like to dig into that a little bit more and talk about our growing toolkit as we think about how to reposition the system to personalize. So how do we go about counseling patients on the different options that are available for them now?
I don't know about you, Mary Jane, but I have a pretty standard conversation that I have with all of my patients that takes into account, of course, the lifestyle measures that we spoke about previously, but outlines options that are reasonable, whether it's hormonal, whether it's drugs but not hormonal drugs, whether it's herbal products or supplements, particularly ones that have been vetted and studied, because after all, we want to provide safe, effective options. And also would include some of the behavioral things like CBT or even hypnosis, which have been, really shown to be effective for at least the vasomotor symptoms of menopause. And, as we have said multiple times, this is an individual decision that gets made shared with your healthcare provider based on your medical history and also your social beliefs. So oftentimes I'll have someone come into my office and tell me right off the bat, listen, I want hormones. Let's just talk about that. And, so I get a direction at least to go in. And by the same token, I'll have someone come in and say, I never want hormones, or I've had this medical issue. Hormones are not for me, so let's talk about other options. And I think that helps to guide the conversation. These days, with so much precision medicine being offered, like genetics testing, or, some of the other how can I put it, scans or imaging or preventative testing and screening that people are having, it's easier to make choices that are appropriate for people and that they'll follow, because compliance is huge. So it's silly to try to convince somebody to take something or consider an option that's just not in their wheelhouse or they're not interested in, because compliance would likely be really low. That's where I found I wanted to broaden my horizons by learning about other options that might not be drug based or might not be hormonally based, because I feel like that different people want different options.
I think it's also important to, when a patient comes in and says, I just want hormones or I don't want hormones, for providers to have that conversation and say, let's talk about all the options, especially if it's that first visit where this is being brought up, to play a role in educating, which also brings me to something where we need communication campaigns to help patients understand some of these options so that the burden isn't just on the clinician. And that helps close the gap and maybe helps also bring a lot more knowledge to that visit so that there's a collaborative conversation. Listen, I'm one of those people that comes in and is like, give me every patch you can. And then it's like, let's have a conversation about this. Let's really talk through it and see that this makes sense for you, with family history and goals and how you want to feel, yada, yada, yada. So I think that that is a gap that's missing that could help with supporting the clinicians in those visits.
Yeah, to your point, I rely so heavily on the Menopause Society and the Meno notes or guidelines or protocols or educational material that they put out, both for healthcare providers, but also for consumers and patients. Because, how many times can you reiterate the same conversation? So it really goes a long way to have those pamphlets and handouts really sitting in your exam room so people can review them or give them at the end of their meeting.
And that was one of the motivators for my website, which shameless self promotion here. What can I say? Please go to my website, madameovary.org. What do you call a gynecologist who studied French in college? That's it. So anyway, but if you go to madameovary.org, you can see listen to, I should say, but listen to these exciting podcasts. And I tell people, what could be better than a dry vagina podcast now, really? So they can listen to Dry Vagina podcasts, Hot Flash podcasts, and listen to all the different options they have. And then I say, and let's talk about it some more after you've gotten some education. And I do think it helps.
I love those. I love your podcasts, Mary Jane. They're awesome.
Thank you.
Yeah.
Thank you. Thank you.
And they do make me laugh.
I think even, with the right tools and the science, many patients are still shifting through a lot of conflicting messages out there about menopause, especially online. So having those reliable resources out there is so critical. But this also poses a unique challenge in the clinic, is that menopause noise that's going out. We're seeing a flood of misinformation and marketing out there when it comes to menopause care. So, how can individuals help patients differentiate between that credible information?
Well, I mean, one of my lines to my patients, and I don't mean to insult anybody out there, but it's like when celebrities, actresses, whatever, come out with these, menopause educational things, it's like I wouldn't teach them acting. We need to, encourage people to rely on scientific medical information as opposed to stuff from celebrities.
The good news is, though, some of the celebrities have really put this topic on the top of minds of so many people. So I do like to focus on that, but you're so right. There's a lot of snake oil going on out there.
And I think that's in any realm of care across the life spectrum. There's a lot of misinformation, which makes it more difficult for the patient and for the clinician to go through those. So I do think that and like you said, they're very reputable folks, that many doctors, WHNPs, who are out there that are dissecting studies and helping break down that information for clinicians and patients that are listening in.
And one of the things that I do refer pay because I get comments and questions from people all around the country, different organizations. And one thing that I will make my plug here for is for the Menopause Society certified practitioners, because that anybody can go, because you'll say, oh, my doctor doesn't, my nurse practitioner doesn't, this one doesn't know anything about menopause, whatever. And I'll say you can always go to menopause.org, which is the website of the Menopause Society. You can plug in your zip code and they will find you people who actually know something about menopause, which is a good idea. So if you find that you are in an area that you're not getting the right answers and stuff like that, do go to menopause.org, plug in the zip code, find a practitioner. And I think that's one of the easiest and most reliable ways to go about it.
I concur. Excellent resource.
That's a great tip. So, as we are thinking about how to adopt care models to better meet patient needs, how important is it to bring in that voice of women who are actually going through menopause? And how do we ensure that their voice is included in how we rethink care for menopause?
I'm going to jump in. The first thing that comes to mind is invite them to the table and give them a microphone. They have a lot to say. And they're like our two clinicians on this podcast. They have grown with their patients and they are experts in menopause care, and they simply need to be invited to the table. Start there.
I'd also like to add that again, it's so important to almost to almost have a team. It's important to know what you know and what you don't know. So, for example, if I have any concerns about somebody's cardiac health and maybe hormone use, let's just use that as an example. I want a cardiologist involved in my patient's care because, medicine has become so nuanced, and really there's so many specialties and subspecialties with expertise. It's really um, helpful to make a better decision.
And it's also helpful to know your reliable sources in your area, who really is interested in this as opposed to who isn't. So, and I mean, I must confess, I will selectively send some of my patients to an estrogen friendly cardiologist as opposed to an estrogen hater cardiologist. And we know they're both out there. So, and of course, and the other area that's out there that maybe I shouldn't say, but nothing stops me from saying anything. That, for example, in the category of oncology and breast cancer patients, particularly, we have 4 million breast cancer survivors in the country. It's a big group of ladies out there. And there are oncologists who will absolutely refuse to let a patient who has a history of atypical ductal hyperplasia use vaginal estrogen, which is ludicrous. And we have to, and so so I know the people. And then, by the way, and I can tell you how they're divided in New Haven. They're called Friends of Mary Jane's and not Friends of Mary Jane. So we know who they are. So anyway, that's true. So anyway, but you have somebody who's, and who has tried some very reliable products. I know that, Alyssa, but sometimes they need a little bit of estrogen on top of it. Reverie's great. But anyway, but if they need a little bit of estrogen, why can't this woman take some estrogen? But there are oncologists that no, 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 no. So you have to know your practitioners of who you're referring people to in your area, as far as getting some advice.
And also for patients to seek second opinions. I think that's also, but that also, with that said, is for those of us who have paid sick time where we can take the time off to go and find that second opinion, who didn't take 3 buses to get to that appointment and lost our hourly wages from that morning because we needed to go to care. So this is where the onus is also on the clinicians to close the gap, and honestly across all specialties, and have these collaborative practice models, which, as you can hear, are sometimes difficult to navigate. We find that in the nurse practitioner world, there are a lot of doctors that don't want to and don't value want to work with NPs and women's health nurse practitioners. I think that's a loss. And I think that we are honestly stronger together and in these collaborative models, and understanding, like, and you just had a beautiful example, understanding the limitations of scope and the need to consult with specialist in whatever those areas are to provide that patient with the greatest possible care and outcomes.
To your point, and I always say that my perspective is probably skewed because here I'm in New York City, and it seems like there's just an abundance of practitioners and really good ones at that. But I think some of the onus truly is just starting to fall on the workplace and the employer to now help their valued employees who are women traversing menopause to have resources through their insurance or through their office, even, so that it doesn't have to interfere with their workday productivity, paycheck access, and all of that. So I think that's something that's coming about, and we'll see how that works out.
And again, I mean, if we can look to the British model, again, they're a few years ahead of us. One study that really, was just amazing was the fact that just by listening to perimenopausal and menopausal women, they realized they needed access to bathrooms.
Yeah.
And no, I mean, it sounds like, have a few more toilets, and that made women a lot better. I mean, that they were much more comfortable in the situation. So you don't have to do, major magical things. Putting in a few proximate bathrooms is a good thing, and that will help.
The thermostat wars, that's a manageable issue.
That's exactly what I was gonna say, and also just readjusting so that you can cool rooms down for people, so that not everybody has to have the temperature at 78 degrees. The menopause ladies aren't gonna really like that. And so simple things that can be done, which are not terribly costly, can really help your workforce.
There's a lot of advocacy across all of our professional associations to bring this forward with bills, congressional federal bills to be introduced to support and include this being part of and included in the workforce. So there is a lot of great work that's happening. It's slow to get past, but we have to keep trying. And my philosophy is to keep looking for the yes because it's out there.
I love that. That's such a powerful point. Keep looking for the yes. So, as we close here, I want to quickly turn toward the future. What advice would you offer to those seeking to take a leadership role in the space of women's health, especially in areas like menopause that have long been underfunded or overlooked?
I would like to say it's so exciting to be involved in women's health, but there's so many avenues to be pursued, whether it's in remaining in clinical care, whether it's going into pharma, whether it's being in the nutritional space, whether it's in counseling. I really feel like broadening horizons and keeping an open mind is just super important because that's how new things are discovered and really was helpful for me.
One thing that really excited me is that the Menopause Society, for years, we had a membership about 2,500 people in the country, internationally as well, in North America. And then our membership has jumped so dramatically in the last 3 to 4 years that this year we are anticipating that we're going to have between 10,000 and 11,000 members. And to go from 2,500 to 10 to 11,000 in a 3 4 year period is just really exciting. And I think people are turning to get some menopause education. So go and get yourself educated, join the Menopause Society, read, go look at the menopause.org website, which you can look at even if you're not a member, to get some education. And the other thing is I think I speak for old folks like myself as far as mentors. Many of us really like to have kiddies around with us, and we like to share with them our experiences and look to them because they'll be very happy to help you.
NPWH supports APRNs, especially women's health nurse practitioners, who are uniquely positioned to lead change and improve menopause care and awareness. The organization recently started 2 years ago a virtual CE course called the Menopause Summit for Advanced Practice Providers, which educates on the latest and greatest, including a holistic, patient centered approach in education that helps in particular, the APRNs in providing that midlife care. I would encourage any of our listeners to take your place at the policy and innovation tables. Raise your hand and bring your voice to the research, to the technology design, to the clinical guidance development, public health campaigns. And like Mary Jane said, get involved in your associations and volunteer and participate and be part of the solution and innovation that we're at a time where, and I think in my lifetime, 10 years from now, this conversation is going to look totally different. And I love Mary Jane hearing that the membership has increased so significantly. That is phenomenal and fantastic. And I feel that anyone that takes care of women should know about menopause care, period. Doesn't matter what your flavor or specialty is. If you take care of women, you need to have this knowledge and education.
Yes.
Well, I think today's discussion has really highlighted that menopause is a universal chapter in every woman's life, but we still face challenges. It's misunderstood, overlooked. But by keeping an open mind, looking for opportunities for innovation, we can change through collaboration and elevating that patient voice to truly look at that full picture for the patient and offer up a personalized approach that will enable the greatest care possible. So, with that, I want to thank my guests for being on the front lines of change and advocating to rewrite the menopause playbook, one where care is personalized, compassionate, and grounded in evidence. And if this conversation has inspired you, as Heather said, raise your hand and please share this episode and join us in amplifying the dialogue around menopause and women's health. So let's keep turning up the volume on women's health together. And until next time, this is Hear From Her.
To our listeners around the world, thanks for joining us today. Tune in as we continue our journey to amplify the voices of women leaders in healthcare. Hear From Her is brought to you by Medscape Education. Please subscribe to Hear From Her on your preferred podcast channel and follow us on LinkedIn. Until next time, remember to lift as you rise.